Welcome everyone. This is Dr. Sharad Jaitly, cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses. So welcome again to this website, MuniMeterHealth.com, which is educating one and all across the globe, primarily to discern and disseminate the information about the human heart and its awareness as well as its illnesses. So welcome again. I'm so enthusiastically seeing increasing number of people now associating with us, and it's so important for us that we get a good feedback from all of you. So without any further ado, I'd like to delve into the subject matter. The subject today is, what are the vasculitides of aorta? In other words, what kind of vascular disease or vasculitis, if you will, inflammation as it's suggested, that occurs in major large vessels, obviously aorta and its branches. So, well, we know that aorta, let's draw the arch of the aorta quickly here. We have this brachiocephalic, and then we have this left carotid, and then we have subclavian here that's emerging out of this, and then we have the descending aorta. So the aorta runs more or less like this, if you will, and again, it's not a perfect arch, but try to draw it quickly. So we have what you call a brachiocephalic artery. This is your left common carotid, and here you have your left subclavian artery. Now, brachiocephalic, if you know, that divides into two, obviously. And what are the two? Well, obviously, it's going to go for the right common carotid, and then this will become the right subclavian artery. So that's how the innominate artery actually divides into. So the three prototypes that commonly affect in various age groups are, one is Takayasu Arteritis, or Takayasu syndrome as it's called, originally defined in Japan, and the incidence there was almost 1 in 3,000 autopsies one would see this to occur, but in the US it's much rarer. It's almost like 1 in a million or so, if you will. So we're really very, very rare in population here, but predominantly it's an Asian prevalence. Etiology is obviously unknown. We know it is very, very similar to the giant cell arteritis, and that's your second that we will discuss here as part of the differential. Giant cell arteritis also mimics just like Takayasu syndrome in that predominantly one sees that the aorta is inflamed. So here we're going to show some little bit of inflammation here. All of this inflammation can occur. In fact, some dilatations can occur, and you may have aortic dilatations, if you will, like this. And the left or the right subclavian arteries could be very, very stenosed, because over a period of time, the inflammation results into stenosis of the arteries. So the stenosis can be seen in these arteries here later on. And at times one can see a bulging of the carotids, and so these are aneurysms that can develop. So all sorts of myriads of conditions that can affect Takayasu, including from aneurysms to stenosis, and do not forget even the ostial stenosis that can occur in the cornea, leading to myocardial ischemia and infarctions. So these are some of your presentations. And then as you go down the descending aorta, one also finds that the renal arteries, because you have your kidneys here, and they are getting their supply. So here you have your right kidney and the left kidney. Right kidney is a little lower because of the liver. So here you have this aorta, which is running down as a matter of fact, and then gives out these branches here. So these branches, the renal branches, they can actually also get stenosed, and it's called renal arterial stenosis. Now that leads to hypertension. So the manifestations could be predominantly systemic or constitutional. So the clinical features are, one has malaise and febrile illness because of this ongoing infection, not an infection really, an inflammation going on, and we don't know what the etiology is for Takayasu as well as for giant cell. So that's one of the issues here. By the way, the third variety is Kawasaki, again defined mostly in Japan, and Kawasaki disease is affecting predominantly the coronaries, if you will. And we'll draw the coronaries here in a second, like this, and one can see the aorta coming out of here from the heart. This is my favorite schematic. The first artery that rises the left main and then divides into two. Not as long here like I've shown, but just for the schematic sense that I've shown this becomes a circumflex. Here is your left anterior descending artery, and all these branches, they of course branch off, and then they meet each other. The right coronary artery is somewhere here. It courses like this from the right coronary cusp, and also gives out branches, and there's a very important branch called posterior descending artery that comes up from there. So these are your coronaries, and these coronaries can actually show huge bulging aneurysms, if you will, like this. And these bulges are very typical of Kawasaki, if you will. And this is the Kawasaki Disease KD. Takayasu syndrome is TA, or Takayasu Arteritis, and then of course you have GCA. So in KD variety, one can now these the KD are very, very young cases. Remember, so we'll just talk about that prevalence in just a second. But these, just so that you remember, these huge aneurysmal dilatation of the coronaries are the pathogenic features of Kawasaki disease. So this is predominantly where it affects it, and normally affects in children like 3, 4, 5-year-old, and past the age of 8 normally one does not see Kawasaki disease, just so that you know. So now let's understand the prevalence. The age group for TA is usually in the 20s, but for Kawasaki disease, it's normally in less than 8 years of age. So it's normally in infants to 3, 4, 5 years of age. That's when they will present. And for GCA, it is GCA, I always call it of elderly. So obviously that defines that these patients are past the age of 60. The median is up to 75. So you would see these patients affected there. So in general, one sees increased inflammation within the intima and the media, and the medial necrosis will occur. There will be a lot of mononuclear infiltrations, and these are granulomatous infiltrations or inflammations. So this granulomatous infiltrations are mostly mononuclear leukocytes. And these leukocytes are constantly affecting the media, and there's a media destruction that occurs. And as a result, therefore, these aneurysmal dilatations may be in aorta, may be in subclavian arteries, may be in carotid arteries, or in the renal arterial areas as well, later on leading to stenosis, of course. So cardiac, central nervous system, and renal manifestations are the major pathogenic and clinical features of these arteritis or vasculitides, if you will. However, Kawasaki has notoriously affecting mostly the coronaries, and therefore that should be just pointed out. And again, the age group is extremely young, like less than 8 years of age. Past the age of 8 years, Kawasaki is not even suspected. But just so that you know, it's normally affecting the infants and the younger age group, and predominantly the coronaries. Now, coronaries dilate, and then later on they can thrombose, and therefore they can have myocardial infarctions. You can also have myocarditis, you can have pericardial effusions. All of this has been defined in Kawasaki disease, and sometimes these aneurysmal dilatations can be seen even on an echo, non-invasively, but invariably a coronary angiography is done, and so these patients can be diagnosed. 70% of these patients will have coronary aneurysms. Now, the treatment is very specific. Remember, the treatment is predominantly because these are systemic constitutional vasculitides. So Takayasu and the GCA both are treated with corticosteroids. Remember that. So they are treated by corticosteroids. So once you have steroids offered to these patients, so Takayasu disease and the GCA can be treated with corticosteroids, whereas Kawasaki disease is treated with predominantly aspirin. And where do I write? Aspirin here, and it's also treated with IV immunoglobulins. And aspirin is primarily given at a higher dose to one for anti-inflammatory, but also for an antiplatelet effect. So this way the coronary thrombosis does not occur and myocardial infarctions do not ensue. Because once the infarction occurs at such a young age, obviously the survival pattern is markedly compromised. But aspirin and IV immunoglobulins have changed the survival pattern whole differently, and now coronary thrombosis and coronary even aneurysmal dilatations are almost not known, or it's in probably less than 5% of the entire Kawasaki disease population. One sees that it's extremely reduced with the advent of aspirin and IV immunoglobulin regimens. So in a nutshell, corticosteroids, very important, because they can really send these two patients into remission, especially the Takayasu and GCA, if you give the corticosteroids in time. High dose steroids, normally 1 milligram per kilo per day, has to be given and later on tapered down, and the effects are immediately seen, like within 1 or 2 days, and within a week pretty much all the symptoms are gone. Whereas aspirin and IV immunoglobulins are the drugs of choice for KD, that is Kawasaki disease. Hypertension is a manifestation because of the renal arterial involvement. Strokes can occur. TIA can be a manifestation because of the carotid involvement here, as I said. And then, of course, the upper body claudication is more prominent than the lower body claudication for simple reasons, because you have more subclavian arterial involvement here, as you see, and therefore the upper body tends to claudicate, shows more signs of claudication in those individuals than the lower extremity claudication. So in a nutshell, you have learned about the vasculitides of aorta, predominantly the granulomatous arteritis, mostly idiopathic variety. But as I said, they have different age groups, and so just keep that in mind. Once again, I want to thank you on MuniMeterHealth.com for being associated with us, and to spread the word. Interns, fellows, residents, medical students, larger the class we have, the better it is, because we can educate one and all here just through our online. Remember to press the like button when you do happen to watch it and like it, of course, and do send me your comments and your suggestions and any questions you have, and I'll make it a point to answer within a short time as soon as I get them, because we get a lot of questions, and again we try to keep up with our answering mechanisms as well. Okay, looking forward to seeing you again on MuniMeterHealth.com, your favorite website for cardiology and human heart awareness. Our goal is to improve the clinical education as well as the patient education, so this way we have a better clinical outcome in our patients. All right, so long. This is Dr. Jaitly from New York.